Well, if you look at the quality outcome measures that we're held accountable to in oncology with regards to palliative and end-of-life care, they relate to mostly the aggressiveness of care that people receive at the end of life. So they are focused much more on end of life than upstream palliative care in the way that I was just talking about it. But that's basically what we have and know right now. And those measures relate to things like whether people receive chemotherapy in the last 2 weeks of life, whether they die in the hospital, whether they utilize hospice care at all, and if they do, whether they utilize it for a meaningful amount of time, more than a day or 2 or 3, for example. And if you look at those outcome measures, unfortunately, patients with hematologic malignancies appear to do worse across the board compared to those with solid organ tumors. And there are probably many reasons why that is the case, some of which we know and understand, others need to be studied a bit more. But if you look at the literature, some of the suggestions include things like differences in prognostication. So in other words, we might have more options that could cure a relapsed or refractory hematologic malignancy, where that often isn't true for a metastatic solid tumor, where you might know from the beginning that it isn't a curable disease setting, and it's just a bit easier to make decisions and talk about that reality when you know that there isn't a chance of cure, even if it's a really slim one. So that's a difficulty that we do face in hematology that's a bit more unique. That said, we're seeing more of that issue come up now in the solid tumor world because of immunotherapies and exceptional responders. So maybe things are becoming a little bit more alike.